A very good morning to respected judges and my dear friends. I am Dr. VAISHALI and today I'll be presenting my case on the topic, an interesting case of intrastromal wooden foreign body following trauma in a young female. Ocular trauma is one of the major preventable causes of ocular morbidity and blindness in children. And it may lead to myriad of manifestations like eyelid laceration, conjunctival and corneal foreign bodies, hyphema, iridodialysis, cataract, RD, globe rupture. Hence, it requires immediate intervention. My case, a 5-year-old girl, she presented to me with complaints of pain, redness, swelling, diminution of vision of her left eye post-penetrating injury from a wooden stick while playing one day back. This is an image showing her left eye full thickness corneal tear with Seidl's test positive in presence of intrastromal wooden foreign body. Coming to examination, on examination we could not assess her visual acuity and ocular motility because she was not cooperative due to pain. Anterior segment examination, conjunctiva had diffuse chemosis with congestion, pupil was fixed and dilated, cornea had an intrastromal wooden foreign body present between 12 and 6 o'clock hours with full thickness central corneal tear of size approximately 9 into 1.5 mm with surrounding infiltrates and stromal edema. Here is a schematic diagram showing her anterior segment examination. Posterior segment could not be examined due to hazy media. NCCT of the orbit revealed left eye flat AC with iris abutting the cornea. The patient underwent emergency surgery of her left eye with removal of intrastromal wooden foreign body with corneal tear repair with AC wash with intracameral moxie under general anesthesia. Here is an intraoperative photo of the patient showing intrastromal wooden foreign body removal measuring approx 7 into 2 mm. Figure 3 is representing the post-op photo of patient showing removal of foreign body and corneal tear repaired with 10-0 nylon and air bubble in AC. We advised her systemic steroids and antibiotics along with topical steroids and antibiotics in cycloplegic. The culture report was negative for any bacterial or fungal element. She was advised regular follow-ups and regular follow-ups were done. Patient's visual acuity improved to 636 with no complications even after 3 months. Here is an image, 3 months post-op photo of the patient with her left eye with corneal opacity after healing of the tear. So my case was unique in the aspect that due to our rapid response and emergency OT services, we made a rapid diagnosis and operated the patient within 8 hours, leading to a better visual outcome and preventing disastrous sequelae like end-of and corneal blindness. Coming to the clinical implication, traumatic corneal tear is a significant cause of uniocular morbidity and visual impairment. And the interesting part is that most of these cases are preventable. So public awareness and education on ocular trauma prevention are essential, along with timely surgical intervention, which is critical. Thank you so much.
Thank you, Vaishali. Even the statement that prevention is better than cure holds true for such cases. Any comment from our experts?
Which antifungal drug you use?
Sir, we did not use any antifungal drug because the culture report came out to be negative.
Negative?
Yes, sir. Yes, sir.
What about hypopion?
So there was no hypopion.
So normally few people know they advocate that even whenever there is a trauma and wooden foreign body is there, you should give prophylactic antifungal. But you are right, if your culture is not showing any organism, there is no point of starting antifungal.
No, I would like to add one point here. Say to know the depth of foreign body entry into the cornea, stroma, better to do anti-segment OCT. At least you know whether you can remove it in the OPD or you can remove it in the...
Yeah, that's a very nice point.
Okay, sir, that we did not do, but we will take care from next time.
Thank you, Vaishali.
Thank you.